Hello and welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Roger Henderson, I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Now you can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook or visit gpnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings. Now, in this episode, I'm going to be discussing rotator cuff tears, something which we see quite a lot of in our surgeries, I think, and I'm mainly focusing on this type of rotator cuff problem specifically today, and we'll cover other problems such as calcific tendinitis and subacromial impingement at a later date. Now, just to remind us that the shoulder joint, or glenohumeral joint, is a ball and socket joint, well known for its extensive range of motion, making it the most mobile joint in the human body, in fact. However, this exceptional mobility does come at the expense of stability. So, unlike the hip joint, which has a deep acetabular socket that provides great structural stability, the shoulder's glenoid cavity is much shallower and is sometimes described as resembling a golf ball sitting on a tee or a basketball on a dinner plate. And so consequently, the shoulder relies very heavily on soft tissue structures, particularly the rotator cuff, for stability. Now, multiple studies have illustrated the direct correlation between the incidence of rotator cuff injuries and increasing age. And in America, for example, rotator cuff pathology is the leading cause of shoulder-related disability seen by orthopedic surgeons there. And I think it's also worth mentioning too at this point that rotator cuff tears are a common feature of normal aging and in fact can be commonly asymptomatic in our patients. So just to remind us about the anatomy of the rotator cuff, this is a group of 4 muscles originating from the scapula and that insert onto the superior aspect of the humeral head, the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. And these muscles play a critical role in both movement and stabilization of the glenohumeral joint. And these muscles work synergistically to maintain the humeral head within the glenoid cavity, preventing excessive translation that can lead to dislocation or subluxation. So, rotator cuff tears have 2 main causes: injury and degeneration. Now, acute tears are usually due to injury, and this type of tear can occur in isolation or with other shoulder injuries, such as a broken collarbone or a dislocated shoulder, for example. Degenerative tears, on the other hand, are more common and are the result of wearing down of the tendon that occurs slowly over time, and this degeneration naturally occurs with age. As you might expect, rotator cuff tears are usually much more common in the dominant arm. And if we look at risk factors in slightly more detail here, these include age, as we've mentioned, smoking, family history, poor posture, repetitive overuse, and trauma. So going through these individually, with age, as we've said, the prevalence of rotator cuff tears increases exponentially with age, and studies indicate just under a 10% prevalence in people under the age of 20, rising to over 60% in those over the age of 80. And age-related degeneration is a primary contributor to rotator cuff pathology, and this can often progress asymptomatically in our patients. One of the risk factors we often forget here is smoking. Now, nicotine reduces blood supply to tendons and impairs healing capacity. It also increases the risk of degenerative tears, as well as delaying post-injury or post-surgical recovery. And studies have consistently shown that smokers have a higher rate of recurrent rotator cuff tears following surgical repair. Looking at family history next, genetic predisposition does play a role in the development of rotator cuff disease, and studies show increased rates of rotator cuff pathology in individuals with affected relatives up to third cousins, so quite a way down the genealogy line. Inherited variations in collagen composition may also contribute to tendon weakness and susceptibility to injury. I think we're increasingly seeing the result of poor posture, with many of us now sitting at desks all day, and abnormal spinal alignment, for example with a kyphotic lordotic posture, can significantly increase the risk of rotator cuff tears. So a forwarded head posture and rounded shoulders lead to altered shoulder mechanics and impingement syndromes, and chronic postural imbalances place excessive strain on the supraspinatus tendon, contributing to degenerative changes. Now, trauma and repetitive overuse are a classical contributory factor to tears here, and sports or occupations that require repetitive and overhead activity, so things like painting, plastering, sports like swimming or baseball, predispose individuals to injury. Any acute trauma, such as a fall on an outstretched arm or heavy lifting, can result in sudden, full-thickness tears. And chronic overuse of the shoulder can lead to microtrauma, along with progressive tendon degeneration, which is often culminating then in a symptomatic tear. Now, although overuse tears caused by sports activity or overhead work can also occur in younger people, most tears in younger adults are caused by trauma, such as by a fall or by shoulder dislocation. Now, one risk I haven't mentioned yet and is very often forgotten about is hypercholesterolemia, because elevated cholesterol levels have been linked to tendon degeneration and reduced tendon healing capacity. Lipid deposition within tendons may actually contribute to structural weakening and therefore increased susceptibility to tearing. And so managing cholesterol levels through diet and medication may in fact help to mitigate the risk of any tendon-related pathology. Now, tears may remain stable over time, or they may slowly worsen. And factors influencing any progression include the size of the tear, the symptoms, the location, with larger and anteriorly located tears more likely to worsen over time. Now, there are quite a number of classification systems out there which we can use with rotator cuff tears, but perhaps the simplest one, and the one I remember, is the Cofield system, which classifies tears according to size. So a small tear is less than 1 centimetre. A medium tear is 1 to 3 centimetres. A large tear is 3 to 5 centimetres, and any tear greater than 5 centimetres is classified as massive. Now, modern imaging techniques and arthroscopy have helped to replace the rather non-specific diagnosis of impingement with specific diagnoses of rotator cuff tendinosis, partial tear, and complete tear. And I think these refined terms do better reflect the degree of damage to the rotator cuff. So, if we look at treatment and management strategies, if we take a general viewpoint first regarding the management of rotator cuff tears, any decision to treat a rotator cuff tear, either conservatively or surgically, should be based on several factors, including the tear size, the age of the patient and their expected normal level of activity, the degree of tendon retraction, if it's present, and whether rotator cuff muscle atrophy has occurred. Now, earlier surgical intervention may be needed if there's weakness and substantial functional disability, or if the pain continues despite several months of physiotherapy and medical treatment. So non-surgical management includes things like physiotherapy, medication, and steroid injections. So physiotherapy focuses on stabilization of the scapula, along with strengthening exercises, and it targets improving a range of motion, reducing pain, and enhancing overall shoulder function. And this can include manual therapy techniques to help reduce stiffness and muscle tightness as well. Now, obviously, non-steroidals can help reduce pain and inflammation, but with all the usual caveats for their use in practice that we would normally think about. And corticosteroid injections can really be helpful here, and a single subacromial corticosteroid injection can be used to control inflammation and reduce pain if rehabilitation and simple non-steroidals are ineffective. And if ongoing rehabilitation is occurring, this can be restarted a few days after an injection. I think it's important to just remind us here that repeated injections should be avoided, since the healing of a potential surgical repair may be compromised as a result. But a steroid injection can also be useful in patients with persistent pain who aren't candidates for surgery. So mentioning surgery, let's look at some of the options that are commonly used now. And these are things like arthroscopic rotator cuff repair, open rotator cuff repair, tendon transfers, and reverse shoulder arthroplasty. Now, with arthroscopic rotator cuff repair, this is a minimally invasive procedure using small incisions and is very good at treating partial and full thickness tears, but is typically considered for patients with both pain and functional limitations who want to return to an active, full lifestyle. Open rotator cuff repairs, on the other hand, are used for large or complex tears that require extensive reconstruction. Tendon transfers are usually only considered for massive, irreparable tears, and this commonly involves transferring the latissimus dorsi or pectoralis major tendon. And this is appropriate for patients with high demands for shoulder strength, and patients who undergo this type of surgery must be able and willing to perform extensive post-operative rehabilitation. Reverse shoulder arthroplasty is only performed in patients with massive irreparable tears and advanced glenohumeral degenerative changes secondary to a long-standing rotator cuff tear. In other words, a cuff tear arthropathy, because this type of treatment alters the joint mechanics to improve function despite a deficient rotator cuff. Now, looking at follow-up, with conservative management, a reasonable plan here would be following up every 3 months for a year, and then every year after this. But after surgery, follow-up typically starts at 1 to 2 weeks post-surgery, with work on a passive range of motion, usually under the supervision of a physiotherapist. By 6 weeks, work on an active range of motion can then be started. Now, post-operative regimes do vary though, and some shoulder surgeons say they prefer not to start any motion work until 3 to 4 weeks after surgery. But as a general point, strengthening can be started 12 weeks post-surgery, and any sport or activity-specific strengthening can then be started by 16 to 20 weeks. Now, the long-term outcomes for rotator cuff tears do depend on multiple factors, including things like the severity and the chronicity of the tear. Smaller tears respond better to conservative management, while larger tears often require surgical intervention. Younger patients typically recover more effectively with rehabilitation or surgery, and compliance with physical therapy and post-operative rehabilitation is absolutely crucial for successful recovery. With surgical repair again, old age, chronicity and retraction of the tear, atrophy and fatty degeneration of the cuff muscle have all been associated with worse long-term outcomes, regardless of the surgical approach. So I hope you found this podcast on rotator cuff tears helpful, but do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. We really do like to hear from you. Do visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.